start, you put it on. Yeah.
Okay.
Okay. And do you have questions?
We will take questions after each session. Yeah.
Each, okay.
Yeah.
So I will be there as well.
Are there also online questions?
It's why I ask you if there are anything that I have to check with the technician. I don't know.
Okay. We'll just take them.
Or ask him.
Take them in the room.
Yeah, I think it's better. I can ask him if he already received something, and usually it's empty, but I can ask.
Is Isaka here? You're there.
Okay, perfect. So, it's okay?
Yes.
Yes. Okay, so welcome everyone to our afternoon session on advances in vaccines and neutralizing antibody development. I would like to welcome all of you on behalf of my co-chair and myself. So I'm Nicola Fiebig. I'm working for BioNTech in Germany, and Christine.
I'm Christine Stapel-Ben. I'm a professor of global health at University of Southern Denmark. And we should say maybe we're both on the EDCTP scientific committee.
Yes.
So that's why we're here, I guess. Yes.
Exactly.
Apart from our big interest in vaccines.
Yes, of course. So for the agenda, we have a packed agenda. We try to keep time. So we'd like to have the speakers finishing after about 15, 16 minutes to give a bit of time for questions. And we'll have questions after each talk because I think it's better that everyone can address questions before you're moving maybe to other rooms and we get the floor to everyone. So, and with this, I would like to give the floor to our first speaker. So Isaka Soumana from the Epicendre in Niger, talking about determining whether mass vaccination campaigns with fractional dose PCV10 could accelerate group protection against pneumococcal transmission in sub-Saharan Africa. So please, the floor is yours.
Thank you very much. Hello, everyone. I'm Isaka Soumana. I'm from Epicenter, Niger. To begin with, I would like to thank EDCTP for giving me this opportunity to present some preliminary results from the FPCV study, which aims to determine whether mass campaign with fractional dose which aims to determine whether mass campaign with fractional dose PCV10 could accelerate herd protection against pneumococcal transmission in sub-Saharan Africa. A study carried out in Niger. We know that vaccination campaign targeting children up to 5 years of age reduce vaccine type carriage and invasive pneumococcal disease. In context of humanitarian crisis, high prevalence of pneumococcal disease, high prevalence of malnutrition or low routine EPI vaccination coverage expected over wider age group, and so even strategies with the cheapest vaccine, if it must be used, will be very costly. Niger is a Sahelian country in sub-Saharan Africa. It is seasonally affected by child malnutrition. PCV13 was introduced in EPI in 2014 using 3+0 schedule. There is no catch-up campaign. Administrative coverage of 3 doses of PCV in Maradi region was 48% in 2018. As you can see on the map, you have in red color the health district of Madarumfa, which is our study area in Maradi. The study aims to evaluate whether a mass vaccination campaign targeting children approximately 1 to 9 years of age with a full dose of PCV is superior to the absence of vaccine in reduction of vaccine type carriage prevalence at 6 months post-campaign, and subsequently to evaluate if a single 20% dose of PCV is non-inferior to a full dose. So we randomized, sorry. Might not. Okay.
Is it okay?
Yeah, good.
Or you want to go back?
Okay. Okay. We randomized 63 clusters in 3:3:1 ratio. Clusters are made up of a village or a group of village very close to each other, sharing a school or a market, and each limited to a population of between 500 and 4,000 people. We did a baseline survey, then a vaccination campaign, and then a follow-up survey 6 months later. We select, in each cluster, we randomly selected 36 households from a census list. Surveys were sampled independently. In each household, study nurses completed a comprehensive questionnaire and then collected a nasopharyngeal swab, which was inoculated in STGG and stored at minus 80 degrees Celsius in our laboratory in Maradi before their transfer in Kilifi for analysis. Analysis did by Camry. For sample size calculation, we considered a baseline vaccine type prevalence 30% with a 50% reduction post-campaign in full dose arm. We considered 7.5% non-inferiority margin between full dose and fractional dose. Now I will present a brief description of study participants. Firstly, there was an even distribution of age group in the different arms of the study. Around 40% children in each arm had 3 doses of PCV recorded in their health passport for the baseline survey. Another 40% did not have a health passport recorded having received 3 doses in EPI. You should note that among the youngest children baseline, vaccination coverage exceeded 70% in each of the study arms with 3 doses in the passport, which is higher than expected. Then in the second survey, you see that the age distribution is almost the same the same as in the first survey, and that the number of children with 3 doses in the health passport is even higher. Campaign coverage with proof of card is 70 and 75%, with 21 and 16% reporting having been vaccinated. This is a good coverage. Then for the main results, as you can see, As you can see at baseline, we observe prevalences of nasopharyngeal pneumococcal carriage of 16, 18, and 19% respectively for full dose, fractional dose, and control arm. After this vaccination, campaign prevalence in the control arm was similar to the baseline. On the other hand, in the fractional dose arm, we observed a decrease in prevalence from 18 to 8%. And similarly, in the full dose arm, a 16 to 5% reduction. At the current stage, the study shows a difference in risk between the different arms with an absolute risk difference of 12% between the full dose and control arms, demonstrating the superiority of full dose campaign versus no campaign. Also, in terms of non-inferiority, the margin between full dose and fractional dose is above the lower limit of confidence interval established at the outset. Bearing in mind that with a much lower baseline prevalence than expected, even if non-inferiority is demonstrated here, interpretation will be much more precise with further analysis to come. The same downward trends in the prevalence of carriage for full and fractional doses are observed in all age groups. Among the vaccine serotype, 4 were predominant: 6A, 19A, 19F, and 23F. For information on the right, you have the non-vaccine serotype mostly frequently encountered in the study, but it should be noted that there are over 100 pneumococcal serotype. For conclusion, finally, these campaigns worked well, especially with the full dose. Statistically, we achieved non-inferiority of the fractional dose compared with the full dose, but this should be treated with caution pending further analysis. Overall, these strategies may be useful for accelerating the achievement of herd immunity in difficult humanitarian situations or in context of low vaccine coverage. I would like to end my presentation by thanking the study participants and all those people and institutions without whom this work would not have been possible. Thank you for your attention.
Thank you very much for the nice presentation and also for keeping the time. So we have a lot of time for questions. If there are any questions, please, the floor is open now. This one.
Yeah, Peter Smith, London School of Hygiene. 2 questions, really. You use PCV10 here, whereas the national program is using PCV13. And I wondered why that was different. And also, how close, in terms of the relevance of the sort of fractional dose, how close is Niger to graduating out of Gavi support, where the issue of price obviously becomes critical?
Okay, thank you very much for your question. For the vaccine used in this study, it is PCV10, which is different with PCV13. PCV13 is used in the EPI. PCV13, Prevenar, is supported by Gavi in our country, Niger.
How close is Niger to graduating out of Gavi support, full support for vaccine supply? Because that's when a fractional dose becomes relevant, when you have to pay for it yourself.
Okay. If I understood your question, the support for Gavi for our government in
Yes.
Supply of Prevenar.
Yeah.
Okay. Sorry, I'm francophone. My English is not very good.
I apologize for my lack of French.
Okay. I don't know. I don't know. I think it is loin? Far away. Far away. Thank you.
Are there further questions from the audience? Because, yeah, I think maybe just for the fractional dose, one is with the cost, the other one might be the availability, and if those two are not a problem, then I think it's maybe better to keep the full dose, but I think there are different components attached to it. A further question? There's one more question.
Bernard Fritzel, I have a question regarding the scale that is being used in your country, the 3 doses at 4 weeks interval. And have you considered evaluating the 2+1 schedule where 2 primary doses would be given first as a primary series, followed by a booster at 9 months, which may have a bigger impact on carriage?
Please come again.
Je vais vous le dire en français. Voilà. Voilà. Dans votre pays, vous utilisez un schéma de vaccination, l'un des 2 schémas de vaccination qui est recommandé par l'OMS, à savoir 3 doses à 4 semaines d'intervalle. Et alors qu'il y a un deuxième schéma qui est recommandé, qui consiste en 2 doses pour la série primaire, et ensuite un rappel donné en général à l'âge de 9 mois pour la 3e dose. Et cette 3e dose est associée avec une réponse en anticorps beaucoup plus importante en quantité, en maturité, et a fait la preuve de son impact sur le portage. Et donc je me demandais, dans l'esprit de votre étude, si vous n'aviez pas considéré aussi l'évaluation de ce schéma.
Ok. Je pense que puisqu'on a fait, on a évalué la supériorité de cette campagne comparé à un bras contrôle où il n'y avait pas de vaccination, et que les résultats aujourd'hui montrent cette supériorité, nous amènent à pouvoir utiliser ces informations-là dans la décision de revoir les calendriers vaccinaux. Donc, nous pensons que nos résultats peuvent sûrement aider dans cette décision.
Thank you very much. We would have time for one more question if there's any. Yes.
Just if you considered looking at sex, because it's well known that females mount a higher antibody response than boys, so that might be that females actually cope better with fractional doses than boys, and you could have sex differential vaccination programs.
I didn't get it. Huh? No, I think in further analysis we will do. I think we can. Yeah.
I think it was just a suggestion for the analysis for looking into the differences.
Okay. Thank you for the suggestion.
So thank you very much. So I think we should move to the next speaker. Thank you very much.
Thank you.
So our next speaker is Jordan Pliskat from the State and Serum Institute in Denmark. I'm talking about the clinical development in Burkina Faso of novel malaria vaccines based on the PFS 48-45 antigens. Thank you very much. So the floor is yours. And
Thank-
also here, please keep time.
Yep. Thank you so much. I'm Jordan Pliskett from the Set and Serum Institute in Denmark, and on behalf of the PIs and the sponsor, Alfred Tiono, Saka Sagara, and Michael Tyson, we're excited to share with you the results of first clinical trials of PFS 4845. So our consortium sought out to rapidly develop and evaluate in Africa multiple novel malaria vaccines. And it started out with 7 organizations across 7 countries, including the US, Denmark, the Netherlands, our clinical trial sites in Africa from Mali, Burkina Faso, Guinea, and Liberia. To complicate things even more, this is accentuated by the support of 5 other organizations, bringing the collaboration to over 12 organizations across 10 countries. With the support from Novavax with the adjuvant, LMIV and LMVR at the NIH, as well as Charles River and Basinex for the manufacture and support of the drug products. We sought out to develop a transmission blocking vaccine. And with the transmission blocking vaccine, we seek to induce in the humans antibodies that are taken up by the mosquito and blocks the parasite development in the mosquito, thereby reducing or eliminating transmission of the parasite. 2 common targets of this are PFS 230 and PFS 4845. These were the first clinical trials of the long sought after PFS 4845 antigen. And to accomplish this, we first fused PFS 4845, or the 6-cysteine domain, to the glutamate-rich protein, or GLRP. And this vaccine is termed R0-6C. Our second malaria vaccine, we took that PFS 230 protein, fused it to the PFS 4845 6C domain with a sequence derived from the circumsporozoite protein, which is also the target of R21 and RTSS. And in doing so, we hoped to make a transmission blocking vaccine also a multi-stage vaccine, eliciting antibodies to 3 individual protein domains in a single vaccine immunogen. The road for this started in 2019. We initiated the manufacture of R0-6C first, and in a staggered approach, manufactured Pro-C6C a year after during COVID. R0-6C proceeded to a first-in-human clinical trial in the Netherlands under support from Horizon 2020 and the OptimalVax consortium. We then initiated a phase 1 clinical study in Burkina Faso where we evaluated R0-6C and Pro-C6C on 2 different adjuvant combinations. Following selection of the optimal adjuvant, proceeded on to a second phase 1 study in Mali where we compared our 2 vaccine immunogens to the PFS 230 EPA TBV candidate. And based upon the results achieved today with Pro-C6C, we look to initiate a small phase 2 clinical study later this year and continuing into next of a challenge study evaluating the multi-stage properties of Pro-C6C. The first phase 1 study was a randomized comparator controlled study in Burkina Faso with the PI Alfred Tiono. And with this, it was a dose escalation study where we used fractional dosing to look at a 30 microgram dose followed by a 100 microgram dose. We did this for both of the protein antigens and 2 different adjuvant combinations, aluminum hydroxide alone and that same aluminum hydroxide drug product with matrix M added to it. We looked at 3 immunizations staggered 4 weeks apart on day 0, 28, and 56, and our primary endpoint was 14 days after last vaccination or day 70. For this, with safety and tolerability, in short, the vaccines, both antigens and adjuvant combinations, were found to be safe and well tolerated. There were no SAEs observed during the study. There were about 118 unsolicited vaccine events. Mostly all of them were mild to moderate, with pain at the injection site the most common AE observed. The most common systemic AE was headache. And I should note that all of those AEs resolved within 7 to 9 days after. Of those, 7 were found to be related to vaccination. And we did this in comparison to the hepatitis B comparator control as well. 2 were attributed to that vaccine. 3 were attributed to R0-6C, and 2 related to Pro-C6C, with headache, again, the most common AE, judged to be related to vaccination. We were seeking then to first look at immunogenicity, and we did this first for the vaccine immunogen itself. So either R0.6C on the top or Pro-C6C on the bottom. And we looked at the two different adjuvant combinations, aluminum hydroxide in red, matrix M in blue. And you can see there the dark lines, either red or blue, are the geometric mean titer, and the individual immune responses are in gray. There's a few takeaways just looking at the immunogenicity to the vaccine immunogen. First, matrix M induced about 2 to 5-fold higher antibodies as compared to aluminum hydroxide alone. This was actually contradictory to what we saw in preclinical studies. Maybe not surprising for a human study, but that's why we chose to take both vaccine formulations and adjuvants forward to the clinical study. The second thing to note is that Pro-C6C with matrix M induced a much more consistent immune response. All those gray lines are much closer to the geometric mean titer. There's a much more consistent vaccine response as compared to R0.6C, where we saw a wide variety of responses from individuals. Again, our primary endpoint was day 70, but we also took trial samples out to day 180 to look at durability. And when we do that, we see for the matrix M formulations, the immunogenicity or geometric mean titer decreases by about 1/3 to 1/2 over that time period. Since this was in an endemic population as well, with prior exposure and current exposure to malaria during the study, we also looked at the hepatitis B vaccine throughout that study duration from day 70 and day 180. And in short, we didn't see any significant antibody responses to the vaccine immunogens itself. Now, we knew that we made antibodies, but the point is to make functional antibodies. And to evaluate this, again, our primary endpoint was day 70. We used the standard membrane feeding assay, or SMFA. And in this, you mix the serum or purified IgG with the parasites, let the mosquitoes feed on it. 7 days later, you dissect all those mosquitoes, you look in the midgut for oocysts, and then you count that. What we saw for R0.6C was actually consistent with what we saw in a healthy population in the Netherlands, that R0.6C only induces sporadic transmission-reducing activity, or TRA or TPV. There's a hashed line there. We consider the SMFA assay accurate above 75-80%. In other words, what you see below that is not kind of a linear scale. There's a lot of noise in the assay. But anything above 75 or 80%, we consider to be significant, and within that 80 to 100% range, also accurate. When you looked at Pro-C6C, what we see with the blue in the middle there on the graph is Pro-C6C induced functional antibodies, and functional being greater than 75% TRA in the SMFA, and 75% of the vaccine recipients. So again, this was the first reported PFS 4845 vaccine antigen in humans that induced a functional response. We were very excited to see that. I should point out this is just the high dose cohort, or the 100 microgram dose. This study was not powered to look at functional activity for the low dose, since it was just strictly for safety. We did evaluate those samples, and we saw a very consistent study, or consistent story, that even a low dose of Pro-C6C does induce significant TRA, but again, given the sample number of 5, it wasn't statistically significant for us to relay. Given that both R0.6C and Pro-C6C share that PFS 4845 6C protein domain, we used just a 6C ELISA. So previously, that was against the vaccine immunogen, or the whole protein. Here, we just coated the plates with PFS 4845 6C, and standardized our reporting to TB31F, which is a clinical monoclonal antibody, against that PFS 4845 45.1 domain. So we know that's a functional transmission blocking domain. And in standardizing the analysis here, we could look at the vaccine response from 2 different vaccines encompassing this vaccine antigen. And again, what we see is 1, Pro-C6C induces a 4 to 5-fold higher 4845 response than R0.6C. And we also see that matrix M significantly enhances that immune response. A few takeaways from this. We're not quite sure, given that the molar mass of the 2 vaccine antigens for that 4845 component are similar, we're not sure why Pro-C6C elicits a higher response to 6T. It may have to do with conformation or the presentation of the vaccine immunogen in humans. We also looked at correlation of that 6C antibody response to the SMFA assay. And for R0-6C, we saw no significance. But in PRO-C6C, we did see a correlation between the 6C antibodies and the functional activity observed in the SMFA. Given PRO-C6C includes that CSP sequence, and this was an exploratory objective of the study, we wanted to look at the immune response elicited by this chimeric antigen to CSP. So first, we have a full-length CSP protein, and we looked at those same human specimens. Again, black line is hepatitis, red line is aluminum hydroxide, and the blue line is aluminum hydroxide in matrix M. We looked at the antibody response to full-length CSP up through day 70. And again, we saw matrix M increases the immunogenicity compared to aluminum hydroxide alone, as well as PRO-C6C does elicit significant CSP-based antibodies. We further interrogated those samples on the right panel, looking at a peptide array. So the sequence of CSP in PRO-C6C is based upon the minor and major repeats. And we looked at both the C terminus, which was a negative control. So in this bar graph, the open bars are day 0, the red bars are aluminum hydroxide alone at day 70, and the blue bars, matrix M, at day 70. So that way we could see pre-exposure for these individuals, given that this is a malaria endemic area. And again, C term, no response observed, which it shouldn't. We don't include a sequence of the C terminus of CSP in this protein. However, when we look at the major and minor repeats, we see a significant antibody response, a 50-fold increase of antibodies against the minor repeat of CSP compared to day 0 for these study participants. We also see a significant antibody response against the major repeat. That's the NPNA3. We looked at 2 different peptides there, NPNA6 and NPNA3. The 3 repeat is seen to be a more specific antibody response, so we utilized that peptide. But again, we saw here PRO-C6C could elicit CSP-based antigens, as well as PFS230 antibodies, as well as PFS48-45 antibodies, and maintain that functional activity or transmission blocking activity. So in short, there's a lot of conclusions to take forward from this first-in-human clinical study. 1, all the vaccines were found to be safe and well tolerated, with no major SAEs and no major AEs. Peak antibody responses, as expected, were observed 2 weeks after the 3rd vaccination, or day 70. And the addition of matrix M, again, contrary to our preclinical data, showed a significant antibody increase over aluminum hydroxide alone. For R0-6C, we only induce sporadic TRA, and for PRO-C6C, we induce statistically significant TRA in greater than 75% of the volunteers, achieving our objective of greater than 75% TRA. And finally, PRO-C6C elicited CSP-based antibodies from the single immunogen. With this, there's a few planned next steps. First, we looked at complement depletion. We don't expect 48-45 antibodies to be complement dependent. PFS230 antibodies are. Punchline, there was no difference with or without complement when looking at the SMFA. We also looked at the functional assessment of those CSP-based antibodies. And I can share with you that utilizing those same specimens from the clinical trial in an in vitro challenge model, we saw PRO-C6C CSP antibodies prevented sporozoite invasion in the liver in that challenge model. We're also looking at antigen depletion experiments of depleting the 230 antibodies and the 48-45 antibodies from PRO-C6C to see what contributes most to SMFA. And what we're seeing is a pretty balanced antigen response that contributes to the functional activity. We had that second clinical trial of TB-VAX2, which just looked at the matrix M adjuvant. And in this trial, we also compare R0-6C, PRO-C6C to the PFS230 EPA transmission blocking vaccine candidate. And as we know, durability of antibodies is important with the malaria vaccine. So we're looking at functional assessment out to day 180 during those studies. And then finally, based upon these results, we plan to initiate a controlled human malaria infection study, a small phase 2 study, where we will administer PRO-C6C with matrix M. After 3 doses, challenge those individuals with sporozoites and observe sporozoite inhibition in that CHMI study. And we hope to initiate that by the end of this year. So with that, I thank first, obviously, our study volunteers, the broad support from GRA in Burkina Faso, our sponsor in Mali, obviously the support of Novavax, the NIH for all the additional analyses, and the team at Satin Serum Institute as well. Thank you.
Thank you very much for summarizing the data here. Are there any questions from the audience? There's one.
Thank you. My question is regarding the design of the study. I noticed that when moving up in the different phases of the trial, you reduce the number of participating countries. One might expect to have the number of participating countries increasing with when the trials goes up. Why this design?
It's an excellent question, and so the question was, why did the number of countries decrease as the study progressed? Ironically, the study originally sought out to make the phase 2 study a multi-site phase 2 study of a selected vaccine across those 4 partner sites: Guinea, Liberia, Burkina Faso, and Mali. So we had planned to do a larger phase 2 study of a selected vaccine across 4 individual country sites. In short, due to delays in COVID and initiating the trials, our whole project timeline got delayed. And so we couldn't get all the sites up to speed for a larger phase 2 within the EDCTP grant. And so we've spent a lot of time training and doing malaria surveillance at all 4 sites, including Guinea and Liberia. And our hope is to involve that effort and the capacity that they built for themselves in future clinical trials. But just in the condensed timeline and with the COVID delays and financial constraints, it didn't happen. So.
More questions?
Maybe I missed it in the beginning, but the sex of your volunteers, did you look at that?
It was male and female. I don't have that breakdown off the top of my head, but it was balanced, at least for the larger cohort. The smaller cohort that just involved 5 individuals, it was obviously a little imbalanced, but there was no difference between males or females in that study.
Then I have one additional follow-up question. For the CSP component that you have in your second antigen or a second vaccine, do you think it would be sufficiently protective to have your vaccine candidate as a standalone, or what is then the plan? Because you showed some immunogenicity data, you're planning some functional data, and in the CHMI, I think you would like to show the first part, if it's an infection reducing vaccine or...
Yeah, so I think the objective of a TBV, right, or a transmission blocking vaccine was always eventually to be compared or co-administered or administered with either RTSS or R21, right? A transmission blocking vaccine alone would not be sufficient for malaria elimination. We think that Pro-C6C, really the selling point of that is it's a single immunogen. And given what we've seen of the significant antibodies that we can elicit in a single immunogen, we're just continuing to evaluate Pro-C6C by itself as a multi-stage vaccine and not looking at Pro-C6C as a boost or a preliminary vaccination to say RTSS or R21. Not that we wouldn't entertain that fact, but just for simplicity right now, we're kind of sticking true to the story of a single vaccine immunogen, cost of goods and manufacture and even ease of administration. And we'll see what the phase 2 shows for whether or not those CSP antibodies are functional in humans. But based upon what we've seen thus far, both preclinically and evaluation of those clinical specimens, we think they will be functional. So.
Okay, thank you. There's one more question, I think the last question. Here. Okay.
Thank you. Just looking ahead in terms of a sort of product development plan, what are your thoughts about how you would evaluate this in a phase 3 study?
So, like many vaccine developers, our idea was always to get through the initial clinical trials and then partner with the organization for larger studies such as phase 3 and implementation studies in that regard. I should mention these vaccine immunogens are manufactured in Lactococcus lactis, generally regarded safe bacterial organism, no endotoxin, things like that. So the ease of manufacture, and the reason we utilize that system is 4845 has a complex disulfide bond structure. So Lactococcus lactis could properly fold it. So in short, it's a technology transferable process that we would basically look to license out to other individuals. And that
Have you got that interest from any sort of people who might do a phase 3?
I think in its current form, we want to get through this phase 2. We know we do not want to alter the vaccine immunogen in any way on a genetic level. We know the sequences work, and we know those sequences elicit good antibodies. So we're not going to play around with the linker or anything else of that CSP component. So we're set from an antigen standpoint. What we think we want to look at is that durability component. With Staten Serum Institute, with our colleagues, we had done a COVID vaccine, and placing it on a VLP obviously increases durability and immunogenicity. So in reality, before we would advance beyond this phase 2, if it shows good activity in a CHMI, we'd probably add this on to our VLP and move that candidate forward, knowing we could increase durability and the magnitude of that antibody response. So,
Okay.
but obviously we're established a good network and consortium of individuals, and we'd like to continue that with all of you as well. So.
Thank you very much. I think that's good last words for your presentation. Let's move on to the next speaker, and thanks to So the next speaker is Ingrid Murillo Jelsbach from the Biofabri in Spain, talking about safety, reactogenicity, and immunogenicity of MTB-VAC in newborns in a TB endemic area, a phase 2A randomized double-blind dose-defining trial. So please, the floor is yours.
So thank you so much to all the people attending this session, and for sure, thank you so much for the EDCTP organization. Okay, so my talk here is just to focus on this phase 2A study that was already carried out in South Africa. And actually, before going to these details concerning this clinical trial, I would like to put in the context concerning the anti-VAC development plan that we have already just involved. As you can see here is the different clinical trial that was already done. And the first clinical trial, the first in human, was located in Switzerland, in Lausanne, was with adults and adolescent volunteers, and was starting in 2012. And then, after this clinical trial with a success data, we go to the phase 1B in South Africa. This was just the first time in endemic area, with neonates in this case. And after that, we go into this phase 2A study that will provide some details about that later. And I would like to show you here as well another phase 1B/2A study that was carried out at the same time in parallel in Sudbury site in South Africa with adolescents and adults, already complete as well. And right now, actually, we are just involved in a phase 3 trial. This is the big challenge that we have in front. And this will be in South Africa and with neonates as well. And the other, and the last on the bottom, you can see the other with the discontinued lines, is concerning the future. The first one is one study, the phase 2A in South Africa as well, but this is a safety study in adults that we started nearly in January, something like that. And the other one is in India. It's the first time we are carrying out any clinical trial with anti-VAC in India. This is a safety study that will be carried out. Actually, we expect to start in January. And last one is another study. This is a future, actually, but we have put in this in the pipeline. It's concerning another big one study in South Africa. We just coming to the phase 3 trial, phase 2B/3. And the last one is concerning the phase 3 trial of the efficacy in India. This is our pipeline. Just a quick mention concerning the first 2 studies, the phase 1 that was carried out in Lausanne and South Africa with neonates, that both has been already published in Lancet Respiratory. You can find out this. And the main conclusion that we have to take into account is MenTVACs are safe and immunogenic. And concerning the main conclusion on the other study, the phase 1B with neonates, is that the lower dose of 10 to the 3 that was used in these 2 clinical trials was discarded due to the lower immunoresponse. And however, another important thing is that the higher doses are more immunogenic than BCG. This is important and really exciting for us at that time. And finally, is the anti-VAC had similar safety and reactogenicity to a BCG vaccination infant. So this is the good point that we can continue with the other study that this is the case. It's the phase 2A study in neonates in South Africa. This you can see here is the partnership, is the consortium, was funded by EDCTP, and the only recruited site was in Sadby, in Cape Town, close to Cape Town. And the other partners you can see is TBBI, the University of Zaragoza with Carlos Martin, that actually is the father of the vaccine. And of course, the other two sites important here is the Centre de Recherche Biomedical Espoir pour la Santé in Senegal, and the other one, Institut Pasteur of Madagascar in Madagascar, that was involved not in recruited babies, just involved in capacity building and to perform in the same time in parallel way the epidemiological data with different clinical trials there. Some details concerning the population of this clinical trial. The target population was 19 babies, neonates, that was vaccinated within the following hours from the birth. And we split the different cohorts from 10 to the 4 to 10 to the 6. This is the highest dose that was tested in this time for the first time. And we was vaccinated HIV unexposed and BCG-naive neonates. As just mentioned, the only site recruited was in South Africa, was in Sadby site. Look at the different data that we observed concerning the immunogenicity. This shows actually the vaccination of the anti-vax in the immunity cells concerning the vaccinations with anti-vax in different doses and in different time points. And you can see here was observed that the anti-vax and the highest dose was highly immunogenic, or the 3 old doses actually, but inducing predominantly Th1 cytokines expressing CD4 cells with a pickup that you can observe in the D56. And another thing important is that the highest dose, the 10 to the 5 and 10 to the 6 of anti-vax, were more immunogenic than BCG, and inducing very similar response magnitude in the phenotypes. Looking at actually concerning the QFT conversions, we saw that all the different doses of anti-vax, 10 to the 4, 5, and 6, was occur a conversion during the D56, about the 80–85% of the vaccinations. And this is another way to see the same one that you can see in this partner of the QFT response. You can see that the vaccinations with the anti-vax dose results are QFT conversions and D56 that I said, and the response waned and reverted to the QFT negative in more than the half of the babies vaccinated after a year from the vaccination time. Look at the different cases of a safety point of view. We will observe that only cases was unconfirmed TB, with not any confirmed TB. Unconfirmed TB that was in the court with the BCG vaccination. And there are 4 other cases that was belongs to the dose level 10 to the 4. So the total case unconfirmed TB that was observed during this clinical trial was 8. Concerning the reactogenicity and the site injection, we can see at the end of the data that was 17 cases was in the vaccinated with BCG, another 17 was with 10 to the 4, and with 10 to the 5 was only 7, and the total with 10 to the 6 was 22 cases. So that means that there are a significantly less solicited adverse events were reported in the 10 to the 5 dose level of the anti-vax. Another view concerning the injections and reaction was concerning the different parameters that was measured during the clinical trial, and we observed at the end that actually erythema and the swelling was the more common frequent event that was observed. And actually, in duration, the swelling were more common as well in the 10 to the 6, in the highest dose. And the other thing is that 12 infants experienced 14 vaccine-unrelated SAEs, including 1 death that was occurred due to bronchopneumonia. So the main conclusion on this clinical trial, there was a dose selection clinical trial, was at the end was decided to go through the 10 to the 5 that the definitive dose level for the future clinical trials, and we expect for the market later on. Of course, this decision was made after a very deep review, incorporated the DSMB, the Data Safety Monitoring Board that was involved in the clinical trial, and another expert immunologist that finally was decided to go through this 10 to the 5 dose level. So this was the key in order to go to the next clinical trial that actually we are just already involved. This is where we are right now, fortunately. So this is another clinical trial. It's just a mention because it's important to know because we are living right now this situation. This clinical trial is just already funded by EDCTP, partially. And actually we have here all the partnerships. It's the same one on the previous study, but we are incorporated recruiter sites in South Africa. In addition, in this case, Senegal and Madagascar are recruiter sites as well, because was performed the capacity building and the preparation in the previous study and was ready to go ahead with this clinical trial. Just to see here what is the location, what is the population and the location of the clinical, all the different recruiter sites. There are 4 sites in South Africa, and some of them has, in addition, satellite sites in order to help us for the recruitment action. And there are the Senegal and the Madagascar, as I mentioned. Concerning population, we have triggered in different stages. The first one is the immunogenicity population, with a total one of 460 participants, divided between HIV exposed and HIV unexposed, exposed, uninfected, and non-exposed. And the other one is the safety population, with a total of a little bit more than 1,000. And then we go to the efficacy population that we need to achieve a little bit more than 7,000 babies. Right now, we are actually just nearly completed the safety population, and we have even more, a little bit more than this recruited number. But hopefully now we have just 1,300 babies. So this is just the situation right now. And this is just the big thanks to all the different partnerships and acknowledgement that we have on the different organizations. Overall, concerning EDCTP, that was it's not possible to share this data if EDCTP is not help for us. So thank you so much.
There's one question in the back. Yeah.
Thank you very much for sharing this data. Beate Kampmann, Charité Center of Global Health. What is your clinical endpoint? Because in your phase 2, you were talking about clinically confirmed TB, so not microbiologically confirmed. I take it for the phase 3, you're going to go for microbiologically confirmed? That's one part of the question, and the other part is, are you still using the Serum Institute of Denmark BCG as your control, or are you using the Serum Institute of India BCG? Every BCG is not the same.
Yeah, it's true. Well, thank you for these 2 questions. The first one is concerning the endpoint of the phase 2A study. Actually was, of course, always the safety evaluation in compared with the BCG and the immunogenicity and reactogenicity of the different babies or adults, depending on the study. For this one is for babies. Actually, the endpoint was a different time point that we already know for the previous clinical trials, that we have to thinking on the D7 after vaccination, the D28, and overall the D56, and then is 6 months after the vaccination at the end of the year. But actually, we know in the previous study that actually the endpoint important here, just to confirm, is how is the immunogenicity and the peak of the different response and the safety for sure on the D56. And concerning the BCG, yes, the strain that was used in all the clinical trials always has been the Danish one.
I was asking for the endpoint in the phase 3.
Sorry, in the phase 3, I was just thinking on the phase 2.
Yeah, because that would be the crunch.
Yeah. In the phase 3 trial is continue with the same one, because we need to confirm the same strain that we are just observed in the different clinical trials, but as well we have the exploratory endpoints concerning TB cases. Actually, TB cases is not exploratory for sure. TB cases is one of the key point of the clinical trial. Now we have to collect the following the strategy that we have for this clinical trial. We have to organize. We already organized a specific interim analysis of the data that was held by different unblind specific person concerning the TB case that we can just to confirm or not confirm that this is a TB cases. And depending on the trend and the results observed done during this time, we can just to speed up the clinical trial and maybe to change some things on the strategy.
Mix of confirmed and clinically
Well,
diagnosed?
the issue is that the only way actually that to confirm any TB case is microbiological criteria. Is we have different time points. We need to say it, and it was the sputum and expert yes. Maybe nevertheless, I have some people here in the room, Bernard, that maybe you can ask or you can apply more detail about that, because it's our advisory immunologist expert with the NTB back.
I think your question relates to the case definition for TB. There are 3 case definitions. Confirmed, that's a classical one. Unconfirmed, sorry. Can you hear me? Okay. So, confirmed, unconfirmed, and unlikely. Yeah. So, the sample size has been is the pool confirmed plus unconfirmed. An unconfirmed case required the combination of specific symptoms of TB that are very well characterized, that have been developed by Mare and his collaborators. X-rays, exposure, and trace of gene expert. One trace would qualify for unconfirmed. And unlikely, it is all the other cases that are, and the primary endpoint for this is confirmed plus unconfirmed.
Yeah, thank you, Bernard. Just to add, we have a specific body for this evaluation. We have an adjudication committee, just performed 5 people and radiologists, specialists, in order to do that. And that's confirm, unconfirm, and just to classify the different cases that is just already in investigation.
Thank you. I think there's one question with a microphone over there, and I think.
Okay, thank you very much. My question is about BCGs have been shown to protect also against other infections, not about tuberculosis. And I know the purpose is to look for an improved vaccine for tuberculosis, but do you think that you can also look if this vaccine you're working on can also protect for other diseases?
Well, actually, this is the question that we have to answer in the future, because actually for the moment we don't know actually if this is 100% protection of the vaccine. So we have to continue with the investigation in order to ensure that the trend is that yes.
Okay, thank you.
I think there's one more question in the front. Could just hand over the microphone, please.
Thanks. I presume the primary endpoint will be confirmed cases, and I wondered what the trial was powered to detect in terms of efficacy and the lower confidence bound on efficacy.
Yeah. Bernard, I think you're the best to answer that. Thank you.
The hypothesis has been to demonstrate 50% improvement in protective efficacy over BCG. Okay? This is
the lower bound or just more than 0?
The lower bound with this approach has not been fixed. It will be, but it has been calculated to have above 80%, 90% power.
90.
But if it turns out that if the true improvement is 50%, then the study has been designed and powered for such. Yeah.
Thank you very much. Any other question? Not so. When do you yeah, there's one more here. And that's the last question. I think then we need to move on.
Peter Arby, does this new vaccine produce scarification in the same way as BCG does? Because the BCG scar is a very good indicator of child survival. So what does this new vaccine do in terms of producing scarification?
I not really well understand your question because the classification of between BCG. Can you repeat?
For BCG vaccination, you use, depending on the site and the training of, you get somewhere between 50 and 90% of the children who get a scar after the vaccination. And that scar is a very strong indicator of child survival.
Yeah.
It's also an indicator of a lot of other things. Well, that would take too long to explain. So my issue is whether this new vaccine will have similar quality in terms of producing a scar which is measurable and can be used in public health.
Well, the data demonstrated that actually the frequency of this event is just less in 10 to the 5 of the MTB value compared with the BCG or the highest other with 10 to the 6. So actually, for us, it's promising that to see that it's lower the cases observed for this event if you compare with the BCG. And doesn't matter concerning the size, because actually in South Africa it's just more or less similar, the events that is until now in the phase 3 trial that we observe. So it's not any specific difference between the different population.
Thank you very much. I think we need, in the interest of time, to move on. So a hand to the last speaker, and let's invite Gabriella Scarlatti from Italy up to talk about a new vaccine to prevent breast milk HIV transmission to HIV-exposed uninfected neonates.
How does this disappear? Oh, here.
Help is underway.
Here we are.
Yes.
It works. So, good afternoon to everybody. You have to switch gear from vaccines to monoclonal antibodies. And I'm here on behalf of the PEDMAP consortium, and will tell you something. We decided to share some preliminary data that we have in this clinical trial that we started some time ago. So you heard yesterday from Slim Karim that HIV reduction is really not, the target has not been reached, and that's very much valid also for children, because despite the great progress since the early days, the HIV response is really failing. And here you see to the left, is it the left? Yes. In the left, you see how the distribution of HIV infection in children is really unequal. Where there is very, very strong presence in sub-Saharan Africa compared to other countries and other parts of the world. Anyhow, what is important is to know how is mother-to-child transmission occurring, and there is essentially two moments where that happens. One is during pregnancy, and the other one is during breastfeeding. So, but what is the reason? And essentially here you see it, it's mothers get newly infected during that period, they drop off therapy, or they are not on ARVs at all. So it's really the virus that is not controlled at all. And pregnancy accounts for the majority, but as you can see on this side, breastfeeding is really contributing to a high proportion of these infected cases. So we thought that this was on the breastfeeding, we should act on this. And and that there is really the need for an effective intervention that is complementary to what is going on already, that is the use of standard of care ARVs that are used usually in children and in mothers. And what we wanted really, as I said, is to prevent mother-to-child transmission via breastfeeding. So we would target the baby, not the mom. And so we thought that it was the time to go for passive immunization. There were proof of concept studies in macaques where several monoclonals were used to prevent mother-to-child transmission, that's oral transmission in baby macaques. We know there were several BNAbs, or broad neutralizing antibodies against HIV, that were tested in adults in phase 1, so they were available also to test in babies. And especially there were some monoclonals that were developed that were long-acting, so they persist in the adults at least several months, and you heard it yesterday from Slim. And last, the proof of concept of the AMP trial, that was a giant trial, where they gave monoclonal antibodies to adults. It was a failure in a way, but on the other hand, it showed that in certain specific conditions, monoclonal antibodies would work. So we decided, oh, sorry, I had forgotten about this slide. The other was, do we have to use one monoclonal or more clonals? There is no hindrance to use only one, but we decided in this case we wanted to use two. In vitro, you really see how the two, here to the right side, there are data in support that show that if you use two antibodies, you cover obviously many more variants of HIV. And here we are speaking of a panel of several hundred of viruses that were tested with these two antibodies. And there is an increase of the coverage, so of the breadth of these antibodies. At the same time, also the potency increases, so you need less antibody to cover the same breadth. So we decided to use these two antibodies. They are directed towards two different regions of the envelope of HIV. The one is VRC07-523LS. It's a CD4 binding site antibody. It's broad, known, also pretty potent, and has already been used in babies. It's the only antibody that was used. I mean, there has been only one trial in babies with monoclonals before us. And that was, but on the other hand, they used a fixed dose and only one dose. You will see what we are going to do instead. The other antibody that we decided to use is CAP256V2LS. It's directed towards a variable region V1, V2 of the envelope. It's highly potent against one of the subtypes, the subtype C that is circulating in South Africa and in a big part of the sub-Saharan or the southern part of Africa. And it's the first time that it's used in babies. So with this in mind, we designed our PEDMAP-1 trial study design. It's a single-blind, randomized, 3-step proof of concept study where we study safety, tolerability, and PK of these two monoclonals that I told you, administered subcutaneously to babies that are breastfeeding, that were HIV exposed, but are uninfected. So the baby has to be uninfected. It's a phase 1 trial. So as you see, it's a 3-step. The first step is the single BNAb. It's a dose escalating. The first group receives arm 1, 5 mg per kilo of CAP256, second group 10 mg per kilo, third group 20 mg. So dose escalating. On the same time, in parallel and randomized, arm 2 and arm 4, we also have decided to have the VRC07-523LS antibody in dose escalating because we wanted to have the precise PK curve, and we wanted also to have a higher dose of what was used in the previous study, the P11-12 study. So the idea is then that we will combine the two antibodies after we have done the first round and combine them in different doses. This same group will receive a second dose because we have to cover the whole breastfeeding period. And usually breastfeeding goes on at least for 6 months. And in South Africa, that means a 4% transmission rate, and that's a lot. And we thought we would give the second dose around 2 months of age of the baby, and then we would have a fourth group where hopefully we could spread these 2 doses apart longer and only give at 0 at close to birth within 96 hours, and then at 3, 4, 5, or even 6 months. So we could cover the whole 12 months period of life or 6 plus something of the baby. Stopping rules are more than 2 children that develop severe adverse events possibly related to the study period per arm. Each arm has 8 neonates, so they are enrolled within 96 hours of life, and our primary objective is safety within 28 days, and the secondary objective is safety and PK in the follow-up of the 6 months of each arm. We have also a series of exploratory objectives that are neutralizing antibody levels compared to the levels of the so the neutralizing activity of the neutralizing antibody level. We would want to also look into BNAbs in the oral secretions to correlate blood compared to oral secretion, because I remember babies drink the virus. And then also look at eventually other side effect of the antibody that might be antibodies. So and some other exploratory objectives that I'm not going into. Where do we run this trial? It's in South Africa, close to Durban, in Chatsworth, at the RK Khan Hospital. It's a sub-regional governmental hospital. Here you see the different places where our team goes: antenatal clinic, maternity, nursery. They do education of the mothers. Oops, what happened? Education, recruitment, screening, and then when the baby gets born, we have a dedicated clinical research unit that is very close to the hospital, where that is only dedicated for PEDMAP, and it was established by South African MRC, and it's where the mothers and the babies can stay as long as they want, also beyond the 4 hours that we follow them in that moment after the administration, and they come back there. So what did we do until now? I said it's preliminary, but we wanted to share it with you already. And Arm 1, so the 5 mg per kilo of the antibody, started in August 2022. We enrolled 8 babies as per protocol and had 100% retention. The 6 months follow-up finished already beginning of this year. Arm 2 and 4, I show you here the statistics together because they, as I said, they are randomized, so we can't separate them really, but the babies were, 16 babies were enrolled, and until now, that is, here I made the cutoff at the ISMC visit in September 2023. We had 100% retention, but we are continued since then, and I tell you that next week we will have the last 2 babies that will have the 6 months follow-up visit, and we close these 2 arms as well. So all visits, I'm glad to tell you that they were conducted within window period. It's not easy. It's, with babies, and it's not easy at all. 1 missed visit in Arm 4, so that's the other antibody, at 3 days, and only out of almost 200 visits, and no early termination. So reactogenicity, that's one of our first observations. We observed the baby at 15, 30, 60 minutes, and 4 hours after BNAb administration at the clinical trial site. Then it goes home and comes back at 3 days. The mother gets a diary where she can sign up whatever she sees. It's a very nice diary. And then it's observed at 3 days at the clinic again. Arm 1, no reactogenicity symptoms. I remind you, it's 5 mg per kilo, so the largest volume they get is 200 microliter. It's very little subcute. Arm 2, that's a little bit higher volume that they have received, but the immediate, there was 1 baby where you could see the dot of the injection, so it's not really a reactogenicity. Within the 4 hours, we had 1 baby with mild erythema that lasted 15 minutes. And then at the 3 days follow-up, we had again 2 babies that had some reactogenicity, 1 with a mild malaise that resolved spontaneously, and 1 with skin rash. So I would say these antibodies given at 5 and 10 mg per kilo are really not reactor. What about the adverse events? Now, the numbers are much higher. Arm 1, the 5 mg per kilo, we have all over the follow-up period, 33 adverse events in 7 babies, 16 are grade 2, and of those 33, 14 are within the 28 days follow-up. All are unrelated and unexpected. Arm 2, the higher dose, there are 25 in all over in the 7 babies, and 13 adverse events within the 28 days, and 1 is expected and definitively related. This was a liver dysfunction, a laboratory assay with elevated AST of grade 1 that was observed at day 28, so the last day of the safety observation, the first, and resolved within 17 days. There was no other symptom associated, so it's really related to the antibody, we think. Mainly it's skin-related AEs, general AEs, respiratory AEs that are observed. Skin means nappy rash, so forehead, whatever, any type of rash that a baby can have. Mothers here know very well what it means, but we have to report all of them. General AEs can be umbilical hernia, conjunctivitis, oral thrush, and respiratory was cold and cough, and it depends very much in which season of they were more or less frequent according of their season. So what about the pharmacokinetics? That's what everybody wants to know, because we have to go for the second dose and we have to know what to do next. So we decided to run the pharmacokinetics with dried blood spots. That has an advantage. We can work with very, very small amounts of blood, so it can be used also in the future with larger studies and not only with the small phase 1. So it's 5 dots of 80 microliter. We have to collect the hematocrit evaluation as well. It's done with a small handy, like diabetes thing, with 1 spot directly there. And I don't go into this because you can see all the details at the poster description at 203. But what I want to tell you is that when the ELISA is prepared, it goes with the hematocrit evaluations, and then it's evaluated by INSERM by Johan Casabou. The observed BNAP concentration, you see, this is arm 1 and this is arm 2. The slopes are, yes, I'm almost done. The slopes are all very much similar. The Cmax is different, it's almost a double. Here I showed you the median. This is 22 microgram per ml, and this is 13 in arm 1. The half-life is around 20 days. And the maximum concentration is on the 4-5 days. But remember that we see the babies at 3 and 14 days, so we might miss really the peak, the actual peak. We asked Johan to perform some simulation because we wanted really to know when do we have to plan the next dose. And here you see he made some Monte Carlo simulation. Don't ask me what it is. It's his business, and he knows very well. And for the 3 doses, the 5, the 10, and the 20 mg, and we have decided to use the target that is 1 microgram per ml that was established for the adults in vitro that could be the protective dose for CAP256. So it's 69 days, 88 days, and 107 days. So it's much, if the ones that were yesterday at the presentation of SLIM, where the curve went on for 6 months, this is less than half. And in fact, the half-time, yes, the half-life is exactly the half of the adults in the babies. So I conclude here, CAP256 given subcut at 5 and 10 mg to babies within 96 hours, doesn't give almost local reactions, gives quite substantial systemic adverse events were observed, but none except 1 were related to the study product. The preliminary PK suggests that we hit the target of 1 microgram, but it's for adults, so completely different type of transmission event between 2 and 3.5 months of age. I didn't tell you, but there are no babies that got infected, likely during all this period, and arm 3 with 30 mg per kilo of CAP256 and also VRC07 are ongoing. I conclude by thanking all the collaborators, or the PEDMAP consortium, and especially the large group at South African MRC that is really has set up a fantastic baby phase 1 facility, and our patients that are fantastic babies, and here they give their 5 when they get out of the clinic. It's a 6 months visit. Thank you very much.
And thank you for a great presentation and a well-accomplished study. We have time for one quick question.
Was too clear. There you are. Good.
There's one question here?
Yes.
Yeah. We'll just take one, and the other one will be referred to the coffee break. I'm sorry.
Hi, thank you so much for that great presentation. I'm curious about the messaging for participants. How did you communicate what BNABs are and how different they are from vaccines?
That's a very good question. It's not so easy, but our nurses and the counselors work very hard to explain them that this is not a vaccine, that they get what is usually the end results of a vaccine, and a vaccine induces BNABs. But you consider that this is in a South African study, so the population already got very much exposed to the AMP trial, and they know very much more than in other places what monoclonals are, because it went on for 2 years. There were more than 7,000 people recruited, and there was a lot of battage throughout. So they're much more aware of what antibodies are than not in other places.
Thank you very much. In the interest of time, we'll move on with the next presenter, who will be Nuhun Barry from Germany, talking about assessment of naturally acquired humoral immunity against malaria, protecting against malaria, I guess, in a controlled human malaria infection. So welcome to the podium. And again, I'm sorry for interrupting the discussions, but it's in the interest of time, and I hope all the speakers will stay around after the session to be available for questions in the coffee break that follows. Welcome.
I can see my presentation. Okay. Thank you. Okay.
Yes,
Thank you.
please go ahead.
Good afternoon, everyone, and welcome to my presentation. Before starting, let me say a few words about my own background. My name is Nuhun Barry. I'm a PhD student from the University of Tübingen in Germany within the framework of Pan-Africa Consortium. I'm also a clinical research and development fellow within the EDCTP2 program. Come from Burkina Faso, from GRAS, the research institute based in Burkina Faso, in Ouagadougou. So now let's jump to my topic. As you can see on the screen, it's about the assessment of naturally acquired immunity against Plasmodium falciparum, protecting against controlled human malaria infection. So, as you know, despite many efforts to fight against malaria, such as the distribution of long-lasting insecticide-treated bird nets, the spraying of insecticide, and the early diagnosis and the treatment of malaria cases using artemisinin-based combination therapy, malaria is still a public health problem in sub-Saharan Africa, including Gabon, which is located in Central Africa, and where malaria is endemic. In fact, around 200 million people become infected with malaria each year, and more than 600,000 people still die from this infection each year. One of the promising tools to fight, even to eliminate malaria, remains the vaccine. Up to date, RTSS and recently R21 vaccine are the first licensed malaria vaccine available. But the efficacy of those vaccines is still far from WHO expectation. So the need of the efficacious vaccine still a priority for the global health. The development of such efficacious vaccine depend on the better understanding of the mechanism of immune response against the parasite. So as a reminder, immunity to malaria can develop following repeated exposure to the parasite, and immune response can develop again all stages exposed to the parasite. A better understanding of the mechanism of naturally acquired immunity and its role in all stages of parasite life cycle may lead to improved vaccine design for the next generation of malaria vaccine. So, our first objective is to characterize immune response against live stage and blood stage parasite antigen from study population in Gabon. Secondly, to measure the effect of repeated infection with Plasmodium falciparum sporozoite challenge on immune response against Plasmodium falciparum. So we are doing our investigation using plasma sample from controlled human malaria infection study, which has been done in Gabon in 2021. It was a randomized open label study, including healthy volunteer adults between 18 to 45 years and resident in Lambaréné, where malaria is endemic. So on this slide, you can clearly understand the design of this challenge study. So we recruit 56 participants and randomize them into two groups according to the ratio 1:1, and we infect the participant 6 times during the study by direct intravenous inoculation using aseptic, purified, vial, cryopreserved infectious Plasmodium falciparum sporozoite strain NF54 or the strain 7G8 from our collaborator, Sanaria. So, in the first group, Group A, we infect participants firstly using 7G8 strain, followed by 5 infections with NF54. In the second group, we infect participants 4 times using NF54, followed by 1 infection with 7G8, and the last infection with NF54. For our immunological testing, we collect blood sample before each infection and at day 56 and day 168. So here I would like to highlight the distribution of the parasite strain we are using in our study. So the black cross represent NF54. It's located around the countries, the African countries cluster, and the second strain 7G8, it's represented by the green cross, and it's located around the South American countries. So that means 7G8 is originated from South America, and the second strain NF54 is common in Africa. So to test the immune response, we are using enzyme-linked immunosorbent assay to test the reactivity of our antibody IgG against the relevant Plasmodium falciparum antigen. So, as a result, you can see there is an increase in terms of the protection following each subsequent challenge. On this heat map, the green box represents protection, the yellow one control, and the red box represent malaria cases. And you can see there is an increase in terms of malaria cases with 7G8 strain after the first challenge. So we notice a significant increase of anti-AMA1 IgG over the first two infections, irrespective to the group. We notice also a significant increase of MSP5 antibody over the first three infections, irrespective to the group. But the CSP antibody response is not induced over the repeated infection periods. So here we did only a few experience with MSP5. So you can see that ETRAM5 antibody are induced in group B, but not in group A after the first infection. So what we can say from our preliminary result, we notice a successful implementation of a repeated challenge model. There is an increase in terms of protection following each subsequent challenge. No specific increase of anti-CSP IgG over the follow-up period of 1 year. Initial increase of anti-AMA1 and anti-MSP5 IgG, followed by a subsequent steady state, which could be due to the saturation of the antibody level or starting protection. So anti-ETRAM5 IgG was not induced in group A, but was induced in group A. That could be due maybe to the genetic diversity between the two strains. So what next? We want to analyze further antigen to understand developing immunity. And we expect also to investigate if there is a change in terms of the avidity and affinity after multiple challenges. We will investigate the role of FC-dependent antibody function and the complement fixation. So here is the end of my presentation. I would like to thank our collaborator, partner, and colleagues from University of Tübingen, CERMEL, Radboud University Medical Center, Sanaria, and DESI for supporting this challenge study. I would like also to thank all of the members of PAM-Africa Consortium and GRAS, my home institution. Thank you to EDCTP, which allow us to be here today, and for supporting my fellowship. Thank you.
Thank you. Thank you for this interesting presentation and daring study. I'm sure there are questions. I can see several, 3 here, here, and here. Yeah.
All right, thank you. It's actually a very interesting study. I would like to know more. But my question is that for your the subject that we are used, were they still exposed to malaria bites? Since it spanned a lot of days, was there control for other infection of malaria? And then the second question is, what happened, what was the transmission in area? Is it a high transmission, a moderate transmission, or a low transmission? Can we expect to have the same immune response in respect of the malaria transmission in that particular area? Thank you.
Okay, thank you for your question. Yeah, our study area, I think it's an endemic area. The participant was exposed to the mosquito bites. There was not a precaution to the measure to avoid maybe other infection. No, they was exposed to the parasites. Yeah. They was using usually like other prevention measure. Yeah. It's okay. Yeah.
Please.
Thank you very much. This is Umberto D'Alessandro. I'm Arsioni de Gambia at the London School of Hygiene Tropical Medicine. Actually, this is a bit of a follow-up of the previous question. I don't know if you measure the immune profile of the participant before including them in the CHMI, but also I didn't hear about the interval between injection. So because I saw that you did 6 injections, right?
Yeah,
but it was not clear for me the interval between the different injection. And also I noticed, but I don't know, in the slides there's only 2 times you had treatment. So I don't know if you did the the injection and then waited for a while and then you treat or not. Thanks. These are my questions. Thank you very much.
Okay, for the first question, so yes, we expected to do the immune profile, using microarray assay. But right now, no, we didn't do anything. But we expected to. Of course, it's very important for And I forgot to mention that the interval between each infection, it was 8 weeks between each infection.
Okay, and the treatment?
Treatment, we treated participant at day 21 after receiving 7G8 because this strain is uncommon in the study area in Africa. So we treated them to avoid, to prevent the transmission of this strain in the study area.
But you didn't treat, you didn't treat. Okay.
Being involved as well, I will add a little bit. And of course, we treated all those who became symptomatic after the infections. And these are around 20-25%. About 20-something% are what we would call sterilely protected. We don't even see any parasites coming out of the liver after infection with the sporozoites. And about half of the people are getting parasitemic, but they are remaining parasitemic at low levels without symptoms. But the ones with malaria or with symptoms we have treated, of course.
Okay, thank you.
Thank you.
Peter, thank you for the clarification. It goes to my question, at least partly. As you know, these sorts of experiments have been conducted both in Gabon and in Kenya, and maybe elsewhere. But so far, to my knowledge, those are 2 countries that have conducted these sorts of experiments. And I think it's true to say what you just alluded to, that in both cases, there's around 20% of the, I think they're all adult participants, who failed to show, at least by the most sensitive PCR assay that we have, that there are any parasites emerging from the liver. I wonder what your interpretation of those findings is. You say they're sterilely protected. Do you think it's really strain-specific protection, or is it more broad?
Sorry, one more time, I didn't get clear. At the beginning it was a comment, but
Okay, well.
Okay.
Should I do it in French?
You can go ahead,
En français.
Bon, ok.
Donc, à ma connaissance, il y a 2 pays dans lesquels ce genre d'infection expérimentale a eu lieu. C'est le Gabon et c'est le Kenya, n'est-ce pas? Dans les 2 cas de figure, à ma connaissance, il y a environ 20% des participants qui ne manifestent aucune évidence par PCR de l'émergence de parasites du foie. Ce qui Peter interprète comme étant évidence de protection, enfin une immunité stérile. Si c'est le cas, comment vous interprétez ça? Est-ce que c'est une immunité stérile qui serait spécifique à la souche, ou bien une protection plus large? Vous comprenez?
Yeah. So I can say anything about that because right now we didn't do any PCR tests. We didn't do any PCR, but I think that if there is a protection, sterilized protection, it could be due to the background immunity. The background immunity, yeah, but I couldn't say if it's specific for the parasite strain or it's due to another strain. But it could be that it could be the what to say, the cross reactivity sometime. So it's very difficult to say if it's due to the strain of another strain.
So the interesting point for me,
yeah,
it's in both countries.
Yeah,
it's the same proportion.
Yeah.
Super interesting discussion, but I think we have to move on to the last presentation. Thank you very much again.
Yeah.
The next speaker is Sebastian Nielsen from Denmark. He is also an associate professor in our group, and he's going to talk about beneficial non-specific effects of all polio vaccine campaigns. Welcome, Sebastian.
Yes, thank you to the EDCTP for allowing me to come here today to talk about the beneficial non-specific effects of the oral polio vaccine and the campaigns.
Shh. Please be quiet.
Thank you. Asking the question if one drop of OPV may have saved more lives than anyone could have imagined. My own background is in statistics. I did my PhD. I've lived 4 years in Guinea-Bissau, so that's also the way I came sort of in contact with the EDCTP. We did a combined trial with Cape Verde and in Guinea-Bissau and in Mozambique and with Portugal. So that's why I'm here today, but talking about something completely different. So to start, let's talk about understanding vaccine effects. So far today, we heard a little bit with the BCG vaccine about the non-specific effects, but really to understand the full effects of vaccines, we need to combine both the specific effects against the target disease and also the non-specific effects, the effects against other diseases, to get the full picture on the effect on the overall health. That is what our data have shown. And so today I'll primarily talk about the oral polio vaccine. So a very old vaccine. It was invented in the late 1950s by Sabin in the US. And in most high-income countries, in Europe and in North America, it's been phased out. But in many or most of low and middle income countries, it's still in use. The plan is that once polio is eradicated, it will be replaced by the inactivated polio vaccine, the IPV vaccine. But with what I'm going to tell you today, maybe that is not a good idea if the OPV vaccine, the oral polio vaccine, have these beneficial non-specific effects on overall child health. So, there's one randomized trial from Guinea-Bissau investigating the oral polio vaccine. This was a trial done at birth, where some children were randomized to receive OPV plus BCG, and other children only received BCG. During the 12 months of follow-up, there was a 32% reduction in all-cause mortality, which you can see in the in the mortality curve being lower in the dotted line of the children that received the old polio vaccine. So a really big effect. What I've been investigating is primarily these campaigns. So the mass immunization campaigns that's been part of this eradication initiative in the world. And as you can see on this graph, this is just to show the amount of campaigns that's been conducted. These are national campaigns in the world in the last 3 decades, and it's more than 2,500 campaigns. And one of these campaigns can be India, so that's like 50 million children. So in total, it's billions of doses of vaccines, which, if they have an effect on overall health, can have had a huge impact on child health. So let's just first also define what is a campaign. We heard a bit about campaigns earlier, but a campaign here is really a mass distribution of different health intervention. It can be one or more. So I already mentioned the old polio vaccine, which is given to all children under 5 years of age. But it's often also co-administered with other interventions. So there's the vitamin A supplementation, which is given usually from 6 months to 5 years of age. And there's also measles vaccines as some of the most common health intervention in these campaigns. You can see some pictures from the most recent campaign in Bissau, where the team is going around, and it's usually conducted in a very short time period. So you have these teams that go around, they find all the children, and the participation is also usually really high. It's in Bissau, it's like 90+% of the children that are found. During this time, the main and the sole focus of these campaigns is really just it is to administer this campaign intervention. Yes. Now we have a campaign. We know it's been conducted, but we also really need some good data. And in a country like Guinea-Bissau, we have the Bantam Health Project, which maintains a health and demographic surveillance system, which monitors the population in a setting where there's no complete civil registry system to sort of follow up what happens to the children that are born and to the people that live in the country. So in Bissau, it consists of 2 study areas. There's an urban study area, which we'll focus on today, but there's also a national representative cohort of villages in the rural areas. So what I did in my PhD actually was to analyze these OPV campaign effects simply by looking at all-cause mortality and looking at the mortality after campaigns and compared it to time before campaigns with oral polio vaccination campaigns. So what we found was that in Guinea-Bissau, we saw a 25% reduction in the child mortality. So that's huge. We also have a study from Burkina Faso, which was a combined composite outcome of morbidity and mortality, which showed a similar beneficial effect of the oral polio vaccination campaigns of 36%. And the most recent study that I did also showed a very positive effect of 31% in the southern rural areas of Bangladesh. So that's great. So now we continued, and we did a study in Ghana, in the northern part of Ghana, in the Navarongo Health and Demographic Surveillance Systems, where we had data from 1996 to 2015. So we analyzed the data, and surprisingly, we found only a 4% reduction in the overall mortality when we compared the time after and before campaigns. So we really asked ourselves, well, is this because there was no effect, or what really happened here? And this is sort of one of the places where, well, when you do science, when you see something that doesn't fit what you've seen before, you search for an explanation for this result. So we need to take all the evidence that we have. We need to triangulate the evidence. We need to say, okay, what can be the potential observations or explanations in the data we had from Ghana? And then we need to go back to the data we had from Bangladesh, Burkina Faso, and Guinea-Bissau, and see if we can find the same patterns in the data as we found in Ghana. So what did we observe that was different in Ghana. So I put some observations here. One of the observations was that they had more campaigns in Ghana, which may be contradictory. You could think, well, that must be a good thing that there's a lot more campaigns because they're good. But that also meant that the first age when the children received the campaign was much lower compared to the two other countries. What was also interesting was that we had analyzed data from Guinea-Bissau and Bangladesh from a later historical period compared to the newest study from Ghana. So really, these were the observations that we had, so we needed to go back to the data from Ghana and then say, okay, what are we seeing that can be related to these differences? And what we need to do, I forgot this, is sort of to find something that can explain and something that can be repeated in the different data sets. That's our methods of triangulating the evidence. So this is the result by age group in Ghana. So overall you see the 0.96, which corresponds to the 4% reduction. But we really see this very interesting pattern where in some age groups there's a negative effect, and in other age groups there's an effect that's more similar to the effect that we saw previously. So what we did was that, well, what if there's some interaction if the children are exposed early to the campaigns? So we did an analysis where we only looked from 6 months, and we looked at the children that were not exposed in the first 6 months of life. The first 6 months of life is also where most of the other vaccines that the children receive are given in these countries. So in Ghana, we found a 22% reduction in mortality, again, comparing the time after and before campaigns with oral polio vaccine, which were more similar to the 40% we saw in Guinea-Bissau in the same analysis, and in Bangladesh we saw a 30% reduction. Also, with regards to the historical period, if we looked at the same historical period from Ghana, so starting in 2004, we found a more beneficial effect, and especially for males, there was a significant beneficial effect, which is also one of the findings that we found in other studies, that usually oral polio vaccine is more beneficial for males. So this was compared to the 25% and the 31% that we have found in Bangladesh. So this is where we are now on the OPV campaign studies. And we have collaborations that have been initiated other places in the world. And well, we're always interested in more studies. So if you have some data and you're interested in participating, then please let me know. And yes, to answer the question, well, yes, one drop can save many lives. And yeah, thank you for your attention.
Thank you, Sebastian. And are there any questions? There, there, and there, and there. The mic is on the way. First in the back, and then Beate and Peter, I think. Somebody here,
Okay.
and the gentleman in the front row.
Hello. I feel this is a really obvious question, and you must get asked it, but the additional activities with the campaigns like access to vitamin A, can you tease those apart, statistically speaking?
We can do it in this sort of same triangulating way that when we look at the effect, and there's a lot more details than I had time to explain here, but when you look at the effect of the OPV campaign and you see the OPV given together with the vitamin A, there's a different effect. So there's not the same effect depending on what campaign you're looking at, and that's evidence enough to say that, well, if it's only some of the campaigns, then it must be something that's actually related to the intervention that are administered in the campaigns, and not the campaigns themselves that do the effect. Yes, that was part of sort of the main argument in my own PhD, that it cannot be the campaign itself. If it's not, then all the campaigns that should have this beneficial effect. Yes, thank you. But good question.
Bad.
Yeah, similarly, also looking at confounders, a lot of countries now also give a dose of IPV as part of the EPI schedule. So have you taken that into account when it started in the various countries, whether there's any interactions? I mean, obviously, gets polio drops at birth as part of the EPI schedule. And then as part of the immunization schedule, I think it's at 4 months, there's a dose of IPV given as well. So, I mean, your data go back quite a bit. I don't know if that was playing a role, but one of the HTSSs went up to 2019. So I think that might play a role. Just look at that as well, maybe.
Yeah, so you're, well, definitely a good point that routine vaccinations can also play a role on the effects that we observe. So what we have also observed in other studies is that the sequence of interventions that children receive, both from the routine vaccine schedule and from the campaigns, that will interact. That there will be differences in what you observe by age and by what is the most and the history of what the children had already received. And one thing can also just be whether the children received or polio vaccine at birth, and if they did it early or late, and sort of the later effect of polio vaccines can really depend on what happened earlier. So it's a good point.
Peter?
Thank you. I just wondered how sharp your falls in mortality were in relation to the polio campaigns, in that some of your pre-periods are quite long, and at least in some countries that's a time when child mortality rates were falling quite a lot during that period. You didn't show any trends, you just showed a before versus after. It would perhaps be a bit more informative to look at that in terms of trends on a sort of annual basis to see how things changed over time, or was it a sharp fall associated with the polio vaccination, or what?
Yeah, so you're saying looking more specifically at like smaller time periods and the effect, and we did look in the Ghana data from Narongo in like 5-year birth cohorts, and found that it was really in the last 5 years that was the most beneficial effect, and really, yeah, but. I also didn't mention that in the analysis we also adjust for time trends and other campaigns and stuff like that. So it is sort of, if there's a skewed distribution of the campaigns over the time period, the historic period, then that is also adjusted in the analysis. Yes.
Then there was. Sorry, was it okay? Yeah, a question from up here. Oh, sorry. You'll just be next.
Thank you for the presentation. Children always die with or without immunization. I want to be sure that you are talking about excess mortality rather than just mortality in general.
I'm not sure. This is all-cause mortality, and what we did in the Bangladesh data was that we actually had data on the cause of mortality also, and we found that it was especially the respiratory infectious deaths that were prevented by the polio campaigns. So I'm not sure if that answered the question, but it's all cause mortality, these analyses.
Question here.
Yeah. I didn't introduce myself last time. My name's Adrian Luthi from IRD in Paris. I admit to knowing next to nothing about polio immunology, but one of the potential confounders that occurred to me was to do with the age of the children under 6 months, because as you probably know, the maternal antibodies can persist out that long. And I just wonder if you've thought about maternal anti-polio antibodies that could be confounding what you're finding.
What kind of antibodies are you thinking about?
Neutralising? Vaccine neutralising?
Polio antibodies.
Polio antibodies.
Sorry, yeah.
But okay, yeah, I should also have mentioned that this is the historical period that we're looking at, even going back in Ghana to the 90s. There's very little polio and polio cases during this period, and I think in Bissau there's 0 polio cases, and it's really not a contributor to the mortality here. There's no specific protection against polio that explains any of the all-cause mortality here. Regarding the youngest age group, well, I'm not an immunologist or a doctor, so I know nothing about that, but I would like to hear more if there's anyone who has
I
something.
think it could be something worth investigating.
I'm sorry, I see more questions now. I refer them to the coffee break because we have to close this session now. We've been ordered and instructed to do it directly on time. So it's 4 o'clock. It's been a thrilling session. So I'm so glad everybody sticked around for this. Again, speakers, please gather here for additional questions, but let us all give them a big hand at the end of this session.